Assalamu alaikum. I am Dr. Asma Hosna, Associate Professor, Department of Pathology, Bashundhara Ad-din Medical College, Dhaka. Hello my dear student. Welcome to you all today's pathology online session. Today is the third lecture of endocrine system. In our previous two class, I have already discussed about hypothyroidism, hyperthyroidism and two autoimmune thyroiditis. One is Hashimoto thyroiditis and another one is Graves' disease. And today I am going to discuss about the rest of the disease of thyroid gland. First of all, what is goiter? So, goiter is a benign diffuse or localized enlargement of the thyroid gland. That means, when thyroid gland is enlarged, this is called goiter, whether it is localized or diffused. And there are two types of goiter. One is diffuse non-toxic goiter and another one is multinodular goiter. Why this goiter is happened or developed? You know, due to thyroid hormone synthesis, iodine is necessary, and when there is dietary deficiency of iodine, it impairs the thyroid hormone synthesis. And impairment of the thyroid hormone synthesis leads to a compensatory rise in the serum TSH level, and that causes both hypertrophy and hyperplasia of the thyroid follicular cell, and ultimately there is a gross enlargement of the thyroid gland, and the compensatory increases in functional mass of the gland is able to overcome the hormone deficiency, ensuring a euthyroid state in most of the cases. What is diffuse non-toxic goiter or simple goiter? Diffuse non-toxic goiter specifies a form of goiter that diffusely involves the entire gland without producing any nodularity. Here the important point is without producing any nodularity, and in case of diffuse non-toxic goiter, the thyroid gland is diffusely enlarged, and it is two types. Number one, endemic goiter, and another one is non-endemic goiter or sporadic goiter. What are the causes of endemic goiter? It occurs due to iodine deficiency in the food, excessive calcium and ingestion of goitrogenic food like cassava, cabbage, cauliflower, etc. And there are two phases we can observe in diffuse non-toxic goiter or simple goiter. One is hyperplastic phase and another one is colloid involution. What is hyperplastic phase? The thyroid gland is diffusely and symmetrically enlarged, and so the follicles are lined by crowded columnar cells which may peel up and form projections. And in colloid involution, when dietary iodine increase or demand for thyroid hormone decrease, the stimulated follicular epithelium involutes to form an enlarged colloid rich gland, that is called colloid goiter. Now come to the morphology. During macroscopic examination, that means gross examination, the cut surface of the thyroid gland is brown and translucent, and in histological examination it reveals colloid filled follicles lined by flattened and cuboidal follicular epithelium. What is the laboratory findings of a diffuse non-toxic goiter? Most of the patients are in euthyroid state. The T3 and the T4 hormone level is normal, and the TSH is elevated or at the upper range of normal. What is multinodular goiter? Due to recurrent episode of stimulation and involution of a diffuse goiter, it generates a more irregular enlargement of the thyroid gland, then it is called multinodular goiter. And virtually all long standing simple goiter converts into multinodular goiter. They may be toxic or non-toxic. Now come to morphology. This is the gross picture of a multinodular goiter. it presents that the thyroid gland is multilobulated and asymmetrically enlarged, and the weight of the gland is more than 2000 gram, and on cut section it reveals irregular nodules containing variable amount of brown gelatinous colloid associated with focal area of hemorrhage, fibrosis, calcification and cystic change. And on microscopic examination, it reveals colloid rich follicle lined by flattened epithelium, and area of follicular epithelial hypertrophy and hyperplasia also seen, and it also accompanied by focal intervening area of scarring and hemorrhage. In case of multinodular goiter, the patient are in euthyroid state. A minority of the patient may develop hyperthyroidism or may become hypothyroid. Now, my dear student, come to the next topics, that is neoplasm of the thyroid gland. Before diagnosis of a neoplasm of the thyroid gland, there are several clinical criteria that provides clue to the nature of a thyroid nodule. We have already mentioned you that normally thyroid gland is not palpable. When there is pathology on the thyroid gland, it can be palpable, and so thyroid swelling, that means it present as a nodule. First we have to examine whether it is a solitary nodule or a multiple nodule, and the solitary nodule are more likely to be neoplastic than the multiple nodule. In case of age, the younger patient are more likely to be neoplastic than those of the older patient, and if the nodule is present in the male, it is more likely to be neoplastic than those of the female. If a patient has history of radiation treatment to the head and neck region, it is associated with increased incidence of thyroid malignancy, and the thyroid nodule that take up radioactive iodine in imaging studies, this is called hot nodule, which is much more likely to be benign, and the cold nodule is dangerous, it is more likely to be neoplastic. Now, the classification of a thyroid tumor. The thyroid tumor can be classified into two categories, one is benign and another one is malignant, and the benign is called thyroid adenoma, and the malignant thyroid tumor are papillary carcinoma, follicular carcinoma, anaplastic carcinoma and medullary carcinoma. And the papillary carcinoma is more than 85% cases, follicular carcinoma occur in 5 to 15% cases, anaplastic carcinoma occur less than 5% cases, and medullary carcinoma occur 5% cases. Now, I am going to discuss about thyroid adenoma, that means follicular adenoma. The thyroid adenoma arises from the thyroid follicular cells, and it produces a solitary discrete mass in the thyroid gland. And why it is happen? The pathogenesis of the follicular adenoma said somatic mutation of the thyroid stimulating hormone receptor signaling pathway are found in toxic adenoma as well as in toxic multinodular goiter. Now, come to the morphology of a thyroid adenoma. This is the gross picture of thyroid adenoma. The typical thyroid adenoma is a solitary, spherical and encapsulated lesion that is demarcated from the surrounding thyroid parenchyma by a well defined intact capsule. And these features are important in making the distinction from multinodular goiter. The follicular adenoma average is about 3 cm in diameter, but some are much larger, that is more than or equal to 10 cm in diameter. And on the cut surface, it present the adenoma is bulges from the surrounding surface and compresses to the adjacent thyroid tissue. On microscopic examination, the constituent cells often form uniform appearing follicle that contain colloid. and the neoplastic cells show little variation in size, cell shape or nuclear morphology and mitotic figure. And the hallmark of all follicular adenoma is the presence of an intact well formed capsule encircling the tumor. And the careful evaluation of the integrity of the capsule is therefore critical in distinguishing follicular adenoma from follicular carcinoma, which demonstrate capsular or vascular invasion. That means, in case of follicular carcinoma, there are presence of capsular and the vascular invasion of the follicular epithelial cell. There are various patterns of follicular adenoma, and they are macrofollicular adenoma, microfollicular adenoma, trabecular adenoma, fetal adenoma, colloid adenoma, Hardel cell adenoma, papillary adenoma and spindle cell adenoma. Then carcinoma. In USA, it is of 1.5% of all cancers, and most cases occur in adult with female predominance. And the predisposing factors are exposure to ionizing radiation during first 2 decades of life, certain thyroid disease such as nodular goiter and autoimmune thyroid disease, and activation or mutation of certain oncogene. Now, I am going to discuss about papillary carcinoma. It is the most common carcinoma of the thyroid gland, and it occurs between the age of 20 to 50 years of age, and the female has predominance than the male, and the ratio is 2 to 3:1. During gross examination, it presents as a solitary or multifocal lesion that may infiltrate the adjacent parenchyma, and there are also presence of fibrosis, calcification and cystic change, and on the cut section the tumor may appear granular. This is the microscopic pictures of a papillary carcinoma, and here there are presence of branching papilla having fibrovascular stalk, which is covered by a single or multiple layer of cuboidal epithelial cell. And there are presence of hypochromatic empty nuclei devoid of nucleoli. These empty nuclei are called orphan Annie nuclei or ground glass nuclei, and also presence of eosinophilic internuclear inclusion or groove and concentrically calcified structure, which is called Samoma bodies. There are some variant of papillary carcinoma like encapsulated variant, follicular variant, tall cell variant, diffuse sclerosing variant and hyalinizing trabecular tumor. And the papillary carcinoma is metastasized through the lymphatic route. So, it is commonly involve the cervical lymph node, and the prognosis of the papillary carcinoma is very good. The overall 10-year survival rate are 92 to 98%. Now, follicular carcinoma. This is the second most common tumor of the thyroid cancer, and the common in women than the men, and the age is 40 to 50 years of age. And the predisposing factors are dietary iodine deficiency, nodular goiter and pre-existing follicular adenoma. On macroscopic examination, that means gross examination, there are presence of a single nodules that may be well circumscribed or infiltrative, and the cut surface show grey to tan or pink on section. And in microscopic examination, it is composed of fairly uniform cells forming small follicles containing colloid with microscopic or extensive invasion to capsule and blood vessels. and the follicular carcinoma spread hematogenously, and so it is spread to the bones, lung, liver, and elsewhere is more common than lymphatic spread. Now, I am going to discuss about medullary carcinoma. Medullary carcinoma of the thyroid are neuroendocrine neoplasm that is derived from the parafollicular cells or C cells of the thyroid, and the cells of medullary carcinoma secrete calcitonin. They also secrete CEA, somatostatin, serotonin, and VIP. On gross examination, there are presence of a solitary nodule or as multiple lesion involving the both lobe of thyroid, and the tumor is firm, pale, grey to tan and infiltrative. And on microscopic examination, the medullary carcinoma are composed of polygonal to spindle shaped cells which form nest, trabeculae and even follicle, and there are deposition of the amyloid within the adjacent stroma. Now, what is anaplastic carcinoma? Anaplastic carcinoma are aggressive tumor with mortality about 100%, and on microscopic examination, these neoplasm are composed of highly anaplastic cells which may take one of the three histological pattern. Number 1, large cell pleomorphic giant cell. Number 2, spindle cells with sarcomatous appearance, and lastly small anaplastic cells. So, my dear student, carcinoma of the thyroid glands are derived from the follicular cell, that means glandular cell. So, on histologically they are one type of adenocarcinoma. That is all about today's lecture. Inshallah, see you again in the next class. Till then, Allah Hafiz.